So Miss S just started on Lantus 10 units. At bedtime, when you ask, I'm sorry, it's Mr. Even a picture of him right there. When you ask him, his doctor told him to titrate his insulin, and he responds, I don't remember. I don't remember how to titrate insulin, my Lantus. So first of all, when should he test his blood sugars so that we have an idea of when the Lantus is effective? Morning. What are Mr. S's blood sugars and A1C goals? Hey, this is great. What do you want his morning sugar to get down to? Whoa, less than 150, I heard. That's great. What was the other one? Less than 130, did I hear? Was it all 150? I thought I heard another one. Depends on which provider you're working with. What do you guys hear? 150 or 130. So I did hear 130. Okay. And 140. We split the difference. You know, this is encouraging to me because it used to be 80 to 110 or 120. 120 used to be considered normal. So I'm glad that at least they're coming up to 130, 140. I firmly believe 150. If you are averaging under 150, what's your A1C going to be? 6.8, 6.7. I'll take that. So I give them a pretty large window to aim for, and oftentimes they can get there. 80 to 150 is a large window. What is their blood sugar goal? I'm sorry, their A1C goal. We just talked about blood sugar. Less than 7. Less than 6.5 if you can do it safely without low blood sugars. I would say if they're on insulin, probably shoot for less than 7. We're doing pretty good. That changes in different scenarios as we get older. We don't have to be under 7 any longer. So I'm more relaxed for my much older patients, especially if they're on insulin. It's much more detrimental for them to get a low blood sugar, fall and break their hip, than it is for them to get complications in 20 years. They might not have 20 years. It's different for different patients because some 60-year-olds don't have a lot of time left, whereas some 70-year-olds have a great quality of life, and I want to protect that as much as I can. 80s and 90s, I'm thinking we don't have to be as aggressive. What's a reasonable titration plan? How would you guys titrate Lantus? 1 unit every day? Sounds like she said that before. 1 unit every day until you reach a fasting blood sugar less than 150. Yeah, I think that's validated with studies. It's safe. Whew. Again, I just got chills. This is great. That's what I do. I say 2 units every 3 days until fasting sugars are under 150. It's not a race. We'll get you down eventually, and I like to do it more gradually. It's safer, I think.
So can you say that one more time?
Yeah, 2 units every 3 days until your morning sugars are consistently under 150. Wow, this is fun. So we go through that with the patient. He understands. Then we see him a month later. Follow-up, and he mentions that he's had 2 low blood sugar episodes. He treated with drinks of 2 cans of regular soda and 3 slices of leftover pizza. That'll fix that low blood sugar. Have you seen this? All right. Have you seen these scenarios? These are real life. This is a great case. It's made up, but it really happens. I had one patient would wake up from a low blood sugar. I'm not kidding. He would wake up from a low blood sugar, and he would treat with a gallon of ice cream. Then he would check, and his sugars would be high, so guess what he did? Blasted himself with lots of insulin and then passed out again. That was a real case. Last time I saw him, I think his A1C was 6.8, no low blood sugars. So what key points, what questions do you ask, and what key points on management of hypoglycemia do you review with Mr. S?
How do you feel after eating 2 sodas?
That's a great question. Yeah. There you go. Did you check your blood sugars before you treated? That's a really good question. And how do we want him to treat? We just went over it, but it's important. Half a can of soda. Yeah. He did great with half of the first 2. If he would have just done a half a can, that would have been perfect. And then recheck in 15 minutes. Make sure you're over Make sure you're over 70. Make sure you're over 15. Yikes. Recheck in 15 minutes. Make sure you're over 70. If not, then get the other half of that soda. Recheck in 15. Yeah. Oh, we're moving on? There was more.
Oh, they're just a little bit out of order, so we can just keep going.
Oh, I see. Okay. So he brings in his blood sugar. Okay, so this is the next follow-up. So we kind of educated him about how to treat low blood sugars. This is the next follow-up. His sugars are at goal first thing in the morning, but then they're in the 200s and 300s at lunchtime and at dinner. So what does that tell you? More Lantus, right? Oh, great. I'm so impressed. I can't tell you how often I see that, though. Blood sugars are high. They must need more Lantus. Then the Lantus goes way up, and then they're having low blood sugars in the middle of the night. But you guys are absolutely right. Their morning sugars are spot on. They're getting plenty of Lantus. Now they need, I heard it, mealtime insulin. So when do you recommend he tests his blood sugars? Is that where we're at? Say it again. Before each meal and at bedtime. The bedtime sugar lets me know how we're doing at dinner. Now, they don't have to check 4 times a day every day, but you can, insurance will pay for 3 times a day because they're on insulin. Get them to check one day before breakfast, lunch, and dinner. Get them to check the next day before breakfast, dinner, and at bedtime. They can alternate.
So if you have this scenario, and say you're working with an elderly person who lives alone at home, and they're just like, I can't manage taking insulin that often, like they can't consider doing bolus.
Yeah.
Is this a time where maybe you think change Lantus to like 70/30?
Perfect. Yes. Yes. And usually those are the great scenarios. Did everybody hear her question? Usually those are the great scenarios where there are creatures of habit and they eat breakfast, lunch, and dinner same times day in, day out, and they eat the same things. So that's perfect for 70/30, and that's exactly right. Okay, so we decided to add mealtime insulin. We decided insulin 4 units with breakfast, 6 units with lunch, and 6 units with dinner. And then he brings in these blood sugar logs. And now it's fun, right? We get to kind of see the patterns. And this is exactly what I like to see. They're checking at least 3 times a day. They're giving me these different times during the day. I can do a lot with this information, right? We see the fasting sugars are all right where they need to be. Doesn't need more Lantus. We see lunchtime sugars are high. We see dinner time sugars are spotty. And this is real life. This really happens. And we see bedtime sugars are. So what can we draw for sure a conclusion with these blood sugars? Okay, diet changes, be more consistent. More insulin at dinner, very good. Consistently high at bedtime. What's my goal at bedtime, by the way? Less than 150? I'll tell them if you're going to be high at bedtime because you're going to go the lowest throughout your night. I don't want you having lows in the middle of the night. So I actually raise that a little to 180. I say if you're under 180, I'm happy with that. But you're right, they need more insulin before dinner. So instead of the 6, what would you go up to? 8. Seems reasonable. And don't stop there. Say, keep increasing that by 2 units. This one I go a lot slower, maybe 2 units weekly until your bedtime sugars are consistently under 180. But that's not all. You guys also told me high at lunch. So when do they need more insulin? Breakfast. Man, you guys are awesome.
But they also might go low by the morning if you're increasing their dinner and they get lower at bedtime. The Lantus might be
Too much.
too much.
Absolutely right. I'm glad you're keeping that in mind. So prime them with that. Say, hey, if you start waking up with low blood sugars or you start having low blood sugars in the middle of the night, can you call me? Or can you reduce your Lantus dose, and that'll be your new Lantus dose? How much would you reduce by? I'm quicker than that. I'm slow to increase, quick to decrease. So I would at least decrease by 10%, depending on how much insulin they're on, 5 or 10 units.
So I heard fairly recently that providers are moving away from prescribing sliding scale. What's your take on that?
Well, I don't have a lot of vested emotion in that. I think that's fantastic. Sliding scale to me is so wrong because what is a traditional sliding scale? It just takes in consideration insulin if your blood sugar's high, not what you're about to eat, right? So inevitably what I see is they wake up in the morning, their blood sugars are perfect, so their sliding scale says you don't need any insulin. And then they sit down and what do they eat? Pastries, muffins, cereal, fruit, not great things for breakfast. And so then by lunchtime, they're always sky high. Now their sliding scale kicks in. They get sliding scale at lunch. So they're reasonable at dinner. So now their sliding scale says you don't need as much at dinner. Most of us eat most of our calories and carbs at dinner. So then they go to bed with the highest sugars of the day, and that's when they get the most insulin as at bedtime, worst case scenario.
So can I ask some advice as you being a provider and me being a case manager? I have a couple patients that are on sliding scale and it's a nightmare. And as a case manager, it gives me headaches trying to help this patient figure their sliding scale out. How would you approach a provider to say, this may not be working, can we consider a different treatment plan here?
So it's easy for me, right? I'm the expert. This is why you've asked me to get involved. I'll take over. But you're right. You're in a precarious situation. I don't know that I know the answer to that question. How have you felt when you've had those conversations?
Well, my providers like to refer to you. So anytime things get out of control, you know.
It's a good point. If you see that and you have a provider that is unwilling to change or unwilling to have some feedback, say, hey, maybe now's a good time for a specialist to get involved, and we can usually sort it out.
So I'm a pharmacist, but I managed diabetes patients in my residency last year. And
Excellent.
I had a patient who was on sliding scale, and the endocrinologist absolutely did not want to take the patient off. And so I just wrote up mock examples of, she had sliding scale plus carb counting with her short-acting insulin. So I just wrote up mock examples and had her tell me, so how much insulin would you inject if your blood sugar was this and you're eating this? And she was off by magnitudes of like 10 to 100.
Oh my gosh.
And so I just showed it to the provider, and I was like, she clearly needs fixed dose insulin because it's a safety issue.
Right.
And then he was like, oh, absolutely.
Oh,
So
that's
I think
great.
if you can just write up like little examples and just tell the patient, like, let's just walk through these to help me understand how much you're injecting and in a non-confrontational way, and then you can show the provider, and then they're normally on board. So.
Is that helpful?
Yeah. Yeah.
Uh-huh.
I have done the same thing and I have found it helpful, but I'm sure a lot of us work with patients whose first language is not English, or we don't share the same first language. And so trying to explain the sliding scale through an interpreter is just an extra piece of complication. And so I almost find it easier to just set an insulin dose, follow up next week, or say I'm going to call you next week.
And then you can make these changes each time. That's beautiful. Now, I want to throw in just one extra piece, and my hope is this endocrinologist was using what I call a correction scale, and I'm totally on board with a correction scale, knowing that we're also covering, and you even said that she's covering the carbs. So if you got a fixed pre-meal bolus, or you've got a carb ratio, and their blood sugar's high before they eat, then certainly you can add to whatever is their fixed dose or their carb ratio. I'm wholly on board with that. I choose not to use that, or at least I'm not aggressive with correction insulin at bedtime. If a type 1 says, I'm not going to bed with a 300, I can't argue with that, but let's be a lot more cautious at bedtime.
So can you go over again real quickly what you would do in
Yeah.
the morning, lunch, dinner?
Great. So what I would do is I would say increase your pre-breakfast insulin to 6 units. And I would say continue to increase this by 2 units every week until your pre-lunch sugars are under 150. Then I would also say increase your pre-dinner insulin to 8 units. Continue to increase this by 2 units every week until your bedtime sugars are consistently under 180. I would also say please take your insulin before lunch and please eat lunch. Obviously this day they didn't check their sugar. They also didn't take their insulin, so their blood sugar was 310. You don't have to check your sugar. You still need to take your insulin before you eat. So,
6 units stay with us.
correct. Yeah, for now, I would just say let's be a little more consistent at lunch to see if a pattern emerges there. Oh, hold on just a second. I would also add the caveat, like was mentioned earlier. If you're starting to have low blood sugars in the middle of the night, or you wake up low, please call, or I would give them a game plan. I want you to reduce your Lantus by this amount. And then keep reducing if you still have lows. Okay.
So you said you were slow to increase but quick to decrease. And in terms of the decrease, what was the numbers that you?
So it's kind of I would say 10 to 20%. So if they're on 20 units, decrease by 2 or 4 units. I also kind of err on the side of reducing too much. So I'll go 5 or 10 units depending on how much they're using. And I'll tell patients, I'm okay if I reduce your Lantus too much. We can slowly ramp back up if we need to, but we've got to get rid of those lows. That's highly important. All right, so now we see Mr. S yet again. You collect his recent blood sugar values, and over the past week, they've been high first thing in the morning. Wait a second, we had the right dose of Lantus. What's going on? He tells you that he loves watching the Olympics, and he stays up all through the night watching the Olympics. So what is Mr. S doing now? Mm-hmm. Popcorn, yeah, all kinds of unhealthy snacks that we watch when we watch the Olympics, right? So what dose change would you recommend in this scenario? A snack change. Stop eating while you're watching the Olympics. You're absolutely right. That's the right answer. Realistically, are they going to stop? No. So what's another answer? Add a bolus before that high-carb snack. So I'll tell patients, I say, look, if you're going to do it, at least take insulin to mitigate how it impacts your blood sugars. It's not a free ticket to eat what you want when you want. I'm not saying that. You still shouldn't be eating those snacks, but if you're going to do it, at least take insulin to cover the carbs. How much would you give? This is where carb ratios really come in handy, huh? But not a lot of patients can do it. Yeah, oftentimes test. You don't have to test. Would you test while you're watching the Olympics snacking? Probably not. Probably not. But it's really important to take the insulin before you snack. Obviously it depends on how much they're taking. With the doses that he's taken, I would probably say around 2 or 4 units based on the size of snacks that he's having. Oftentimes, if they're taking a mealtime dose, I'll give them half or a quarter of what they take at meals as their snacks. Does that make sense? What additional education? I think we already said stop eating. Maybe snack on carrots or celery sticks or broccoli. Dawn phenomenon. Does everybody know what the dawn phenomenon is? What is it? You nodded your head.
Isn't it just like a huge crash?
That's a really good next thing. But no, that's called something else. Do you know what that's called? So he says it's when your blood sugar crashes in the middle of the night and then you wake up high. And the Somogyi effect, correct. So that's when you crash and you wake up high. The Dom phenomenon is your blood sugars are fine through the night, and then we all get a boost of cortisol right before we get ready for our day. If you have a functioning pancreas, your blood sugar you'll wake up normal. But for a lot of these patients, their pancreas isn't functioning, so they can wake up high. That's the Dom phenomenon. So how do you treat the Dom phenomenon? So the longer you go without food, the more robust that Dom phenomenon is going to be because you're also engaging the liver to produce sugar for you when you don't eat. So one way to kind of help with the Dom phenomenon is to have a snack at bedtime. In particular, a low carb, high protein, even some healthy fats at bedtime. Nuts are the perfect bedtime snack. A handful of almonds, cashews, or walnuts give you omega-3 fatty acids you need anyway, and will help keep the liver off overnight to help with this Dom phenomenon. It also helps protect you from lows in the middle of the night, so it's also protecting you from the Somogyi effect. Remember, it's a handful, not volumes of nuts. Peanuts are not nuts. They're actually legumes. So I tell patients almonds, cashews, walnuts, not peanuts. And then rule out the Somogyi effect. How can you rule that out? Have them check their blood sugars at 3 in the morning or in the middle of their sleep schedule. Let them know you only want them to do that a few times, I had one patient doing that on a consistent basis for months. I'm like, oh my gosh, you didn't have to do that. So blood sugars decrease in the middle of the night. You get a rebound hyperglycemic effect. It's bad if this is happening because often the nighttime insulin gets increased. So patients will wake up with high blood sugars. Actually, they wake up with variable blood sugars. Sometimes they'll be 80, sometimes they'll be 300. That should make you think, oh, I wonder if they're having these overnight lows. But what can happen is you increase the Lantus, and now all of a sudden the morning sugars get even higher. Then it should make you really think, oh, they're probably having lows in the middle of the night. Let's back off on the Lantus and see what happens. Usually their sugars will come down if this is the case. You can also use a continuous glucose monitor, which will show you what the blood sugars are doing all through the night. And you'll see that dip and then that rebound effect. Mr. T said he was too busy to remember to take his insulin. He works in a warehouse loading trucks and locally made bike bags. His job requires, this seems new. His job requires that he takes lunch and breaks at regular times to coordinate, oh, this sounds familiar, his coworkers' breaks. Mr. T's doctor started him on 70-30, 20 units, 30 minutes prior to breakfast and dinner. So why is it important for him to take regular 70-30? I shouldn't say regular. I should say Humulin 70-30 and Novolin 70-30. Why should he take it 30 minutes before breakfast and dinner? Say again? The onset, right. So if it's Novolog 70-30 or Humalog 75-25, they take it right before they eat because it's got the log in there that acts fast. If it's the old stuff, it's much cheaper, but you got to take it 30 minutes before breakfast, 30 minutes before dinner. How can you double check that the dose seems reasonable?
How much does Mr. T weigh?
Ah, there we go. That's where we're headed. So look at his weight in pounds. Do you guys remember how we came up with doses? First two digits. Again, it's a starting dose, so if it's more than that, it's probably still okay. But my guess, Mr. T is not a thin fellow, so these are probably correct doses for him. So 2 weeks later, follows up, last week he had 2 low blood sugars in the afternoon. He said his job's been really stressful since one of his coworkers called in sick, or has been calling in sick. He's had to skip lunch twice to cover his shift. Why is he having low blood sugars? You're skipping lunch. So either 70-30 is not the right insulin for Mr. T, or he's going to have to tell his boss, look, I have a medical excuse. I have to have lunch every day at this time. Or carry something with you so that while you're working, you can grab snacks or something to prevent yourself from having low blood sugars. So when should you refer to a specialist? Again, my favorite scenario, I guess I can't speak to other specialists. My hope is that one of the most fun things for them to do is a new onset type 2 with an A1C greater than 12%. Please, please, please let me get a crack at them first because I can do so much good right at the beginning that pays off years down the road. Also, if they're uncontrolled and they're already on basal bolus insulin therapy, they're probably not doing it right. There needs to be a deeper dive to kind of find out what are the idiosyncrasies that patient is missing. And we can oftentimes come up with those. Gestational diabetics, actually, they're not that difficult to manage, but probably you don't see a lot of them, whereas we do. So send them our way. It's critical that they are involved in taking action. Type 1s, most primary providers aren't comfortable taking care of type 1s, so they probably should come to us. There are some primary care providers who are type 1, and they're very comfortable taking care of type 1s because they take care of one themselves. And then insulin pumps. We're used to working with insulin pumps. Again, most primary care providers aren't. One thing that you guys can help keep in mind is if there's a pump malfunction, what do? They're going to call you first, right? And you're going to be like, I don't know. So if they have a specialist, they can certainly call us, but more importantly, they can always call their pump manufacturer. In particular, if it seems like the problem is with the device itself, we'll even direct them back to the pump manufacturer. If it's more of a treatment issue, like either the setting is not correct or you're seeing a pattern that is wrong, and you don't know how to change the pump, send them to us. We're used to addressing those. Did I handle? Yeah. Cool.
So I know you said for the new onset type 2s with the A1C of greater than 12, refer right away.
Mm-hmm.
I know sometimes what we run into with our patients is we do refer immediately, but they're looking at a 4 to 6 month wait before getting in to see endocrinology.
Yeah, I don't want to wait
then
that long.
In the meantime, you know, we're starting with Lantus, but we're not doing your, you know, the basal bolus like you do.
Mhm.
You know, are we causing more damage by starting
No,
with
no.
something
By getting
like
them on
basal?
insulin right away, you're still helping the situation. A little insulin is better than no insulin. So I wouldn't say that, no. Yeah, my hope is those barriers are becoming less and less, and we're working them in quicker eventually. Eventually, maybe. I hope. But keep them in mind, especially if they're on our side of town. Surgery. What about bariatric surgery? Do you guys ever have this discussion with your patients? So I used to be a big proponent of gastric bypass. I felt like, yes, it is extreme. It's not right for every patient. However, there's some huge benefits to gastric bypass. When you do the gastric bypass, essentially you reverse diabetes before even the weight loss occurs. When you divert the food around the stomach, diabetes goes away. So I was a big proponent, again, as an end stage treatment, let's try all the right ways first, and if you fail, it can be a life-saving treatment. However, recently, the surgeon that I use in the area, Emma Patterson, has started doing the gastric sleeve, and she has seen some tremendous results with the gastric sleeve. At first I was reticent. I'm like, well, if we're going to go through this surgery, let's do it the right way. Let's cure the diabetes and make sure that the weight loss is permanent and effective. She's been seeing great success with many fewer side effects and complications with the gastric sleeve. And just like it shows, you just cut out a portion of the stomach to reduce the volume that they can eat. You're getting the same benefits as gastric bypass. The diabetes doesn't go away instantly, but with weight loss, obviously everything's getting much, much better. And what's really kind of sold me on this, it's much less aggressive, and you can still do the gastric bypass if it fails. Once you do the gastric bypass, obviously you're done. You can't do anything else after that. With this one, it's much safer, it's still very effective, and we still have the gastric bypass as an option.
I have a couple of friends that have had to get the bypass surgery, and it just seems like it's like a cascade of problems that they have after that.
So bypass surgery has a lot of complications associated with it. I have also had a lot of patients who have had great success. So my hope and my thought might be is, who's doing the surgery? Emma Patterson is the one I use exclusively in this area, and she does an amazing job. Your chance of complications go way down in the hands of an experienced surgeon, and she's fantastic.
When do you go this route?
Again, it's kind of end-stage treatment. You've been working with this patient, and it's obvious there are no changes on the horizon. They are not going to fix themselves. And now you start looking at, well, if they continue where they're living, their lifespan is about here. I know I can extend that, granted with a aggressive procedure, but in my mind, then it's worth that risk. Does that make sense?
Yeah, I mean, are you talking about people who are non-compliant? Are you talking about, because if they're non-compliant already, and they have the surgery,
there's still a chance that they can out-eat their gastric bypass, but even in those scenarios, it forces you to be compliant, and you have a lot better chance of being successful.
Just going to, generally speaking,
Sure.
reducing insulin dosage after a gastric bypass or gastric sleeve, when to, how much?
I'll be honest, the surgeons and the support team around the surgeons, they take care of that before they come back to me. Gastric bypass, usually they're off before they come back to me. Gastric sleeve, they're on a whole lot less if they're still on it, and then I can wean them the rest of the way as they continue losing weight. All right, let's get back into the cases. These are my cases. So Mr. Tubby is a 42-year-old type 2 who weighs 310 pounds. Comes in for hyperglycemia. He's been on oral since he was diagnosed 12 years ago, and he's never been in good control. And his wife, Telly, see what I did there? Telly Tubby, thank you. States that his sugars are in the 200s in the morning, but then 300s and 400s later in the day and evening after he eats. So it's pretty obvious to me what this guy needs. What's he need? Insulin. Yeah, basal and bolus insulin therapy. He needs both, right? He was given a bolus of insulin in the ER, and now his blood sugar is 130. His A1C is 14%. My favorite case, right? No using 70-30. Let's come up with basal bolus insulin regimen and sensitivity factor for this guy. So let's go ahead and use 70-30 for this guy. Let's just say he will commit to eating breakfast, lunch, and dinner. He will commit to eating at the same times day in and day out. He'll commit to checking his sugars before breakfast, before dinner every day, and taking his insulin before breakfast and dinner every day. And he will also, did I already say commit to staying with the same amount of carbs day in and day out? So this might really work for him. So let's consider 70-30 for just a second. How much insulin should we start him on? 31. Isn't that cool? So easy. It's safe. It's an easy, good place to start. Do I have a case of titrating 70-30? Where'd Tara go?
I don't think so.
Okay, so let's go through that for just a second. Yeah, I think this is very valuable. So we start Mr. Tubby on 70-30. We start him at 31 units before breakfast, before dinner. When do I want him to check sugars? Before breakfast and before dinner. That's really the only two that I need. And then this is how I titrate. I tell them to increase their pre-breakfast insulin by 2 units every 3 days until their pre-dinner sugars are under 150. I also tell them to increase their pre-dinner insulin by 2 units every 3 days until their morning sugars are under 150. It's that simple. So, 310, first we have to calculate his weight in kilograms. Can anybody do that? Yeah, 2.2. So 310 divided by 2.2 is? Yeah, feel free to use calculators. You can cheat. 141. So total daily dose, do you remember this? Is 0.5 units per kilogram. Remember, it's 0.5 to 1. So eventually, he may need 70 units of Lantus, which is half of 1 unit per kilogram, right? But I like to start off a lot less than that. In fact, I would have started not 55 units, I would have started 35 units. I think 35 units would be safe. So this is really helpful. Again, most of these patients are getting started at 10 units and then come back and see me in 3 months. 10 units is nothing for this guy, right? I would also use a carb ratio if he can count carbs, if he's good at math. And it just depends. Some patients are, some patients aren't. But if they're willing, so if we're going to start with 35 units throughout the day for mealtime boluses, we can either divide that by 3, right, to get a fixed pre-meal dose at each meal. Or, again, if we use that 360 divided by total daily dose, that's 360 divided by 70. What's that? You can start a carb ratio 1 to 5 for this guy. Again, I jumped to the end stage. I'm using 1 unit per kilogram. That's where I came up to the 1 to 3.5. But I would be uncomfortable starting 1 to 3.5 or 1 to 3, 1 to 4. I would start at least 1 to 5, if not even 1 to 10. Again, it's better to underguess their bolus needs than it is to overguess. You can always tighten it up later. A lower sugar is still better than where they were, and we don't want to get them too low. Sensitivity factor. What is a sensitivity factor? A sensitivity factor is how much 1 unit will drop their blood sugar. You can calculate this based on their weight in kilos again. I use what's called the 1500 rule for type 2s and the 1800 rule for type 1s. It's 1500 divided by the total daily dose, or 1800 divided by the total daily dose. So for this guy, again, his weight in kilograms is no, we decided his total daily dose was going to be 70 to begin with, right? So 1,500 divided by 70 is? 1,500 divided by 70? $21? Is that what I heard? Yeah, 21. So 1 unit will drop him about 21 points. Now again, my scenario is he's closer to 1 unit per kilogram, so that's where I got that 10.6, but I think 21 is reasonable. The other thing that I do is I kind of say my type 2s, I'm going to use 2 units per 50 over 150. My type 1s, usually I use 1 unit per 50 over 150. So 2 units per 50 over 150 is a sensitivity of 25, so I'm in the ballpark, right? What I mean by that is if their blood sugar is between 150 to 200, they would add 2 units to their carb ratio. If their blood sugar is between 200 to 250, I would add 4 units, so on and so forth.
Is that kind of the correction scale you were referring to?
That's the correction scale I'm referring to. You can also use what's called a sensitivity. You can plug that into a pump, and the pump will use that to determine how much extra insulin they need when their blood sugars are high. It's cool, isn't it? Okay, case number 2. Oh, these are really fun cases. I was hoping to get to these cases. So 44-year-old routine random serum glucose was 271. Symptoms of the past year has been frequent infections, polyuria, polydipsia, and weight loss. Classic diabetic, right? So what type is he? You don't really have much to go on right now, but you're thinking type 1, type 2, right? He's been having weight loss. He's 5'9", 197 pounds with BMI of 29. His maternal grandmother was type 2 later in life, and she was very obese. He's got no signs of insulin resistance, which you would see darkening of the skin right here on the neck, acanthosis nigricans. His A1C was 12.5, again, my favorite scenario. Blood sugars range from 170 to 500. So this guy, it's not really clear, is it? Could be a type 2. Maybe not. So is he a type 2, type 1, a LATA, double diabetic, or type 1 from a secondary cause? Don't know. I'm thinking either he's a LATA or type 2. So here is where finally we got to this information where you can check. Autoantibodies. So I do an anti-GAD. I used to do anti-insulin. I don't do it anymore. And anti-islet cell antibodies. You can also do a fasting C-peptide, which will let you know, is he producing insulin? Obviously, if the autoantibodies are positive, now we know it's type 1 or LATA. We also know if the C-peptide is positive, it's type 2, because if the antibodies are negative and the C-peptide is positive, we know he's producing insulin, so this is a type 2 scenario.
So this would be the screening if you just found them?
Correct.
They're coming in for the first time?
Yep.
You just screen them with that?
Yep, I do my autoantibody panel. It's my panel that
Medicare,
It's
do
an
they
Epic.
cover, because I don't think they cover screening, do they, Medicare?
Medicare?
Or, yeah.
That one I'm not sure. I haven't had.
CareOregon does
Yeah, does CareOregon pay for these?
that? I'd have to double check on the Medicare, the tests.
I feel like I order these for those patients and I haven't had any
So,
problems,
but I'd
right?
have to double check to confirm.
There's another provider in your clinic who I took a patient to and who were concerned that maybe, it was LATA or something, and she said that it wouldn't be an accurate result unless the sugars were in a better range.
So my guess is, and usually we do these testing for pumps, and you do need normal sugars if we ever wanted to consider a pump. So I'm wondering if she had that in mind. It's what we're used to doing.
But in your opinion, it would maybe be
Still beneficial. Again, if the antibodies are positive, you got your answer, and if the C-peptide is positive, you got your answer. But what this guy was, everything was negative. So autoantibodies were negative, but also the C-peptide was low. This could also be what she's talking about. Right now, just like I said, due to the glucose toxicity, the pancreas is shut down, so the C-peptide isn't working. The pancreas isn't working, so there is no C-peptide. Doesn't tell me if it's type 1 or type 2 yet. So I still didn't know with this case. So what do? Again, my favorite thing to do is, here he started checking his sugars at home. Blood sugars in the morning were that. Blood sugars after breakfast were that. Oh my gosh. And at bedtime, once he checked, it was 295. So what should we use for this guy? Again, my favorite scenario. Ooh, great answer. In reality, though, what happens? Metformin, right? Metformin, come back and see me in 3 months. Oh my gosh. So send them to me. Basal bolus insulin therapy, ensure control. If he is a latent autoimmune diabetes of adulthood, I'll bring those beta cells back online. And I'm sorry, if he is a latent autoimmune diabetes of adulthood, he needs to be on this anyway, right? If he's a type 2 and he's glucose toxic, then I'm bringing those beta cells back online. And after about 6 to 8 weeks, we'll need to stop insulin because he'll start having low blood sugars. He continues to use basal bolus insulin to this day. So he is a latent autoimmune diabetes of adulthood. He's done fantastic with it, though. I do feel that he's still in the honeymoon phase because he's already gotten his A1C 6.6 years down the road with no low blood sugars. You don't see that in real type 1s. If they have no pancreatic function, it's really hard to get 6.6 with no lows. This guy's a LATA who's got a nice, robust honeymoon phase, probably for quite some time.
So does the treatment plan change, though, really, ultimately, if they have LATA or type 2?
It's a great question.
Or is it more just kind of...
So certainly with the type 2, I would have my answer because he would be getting low blood sugars all the time. And we would be on the phone reducing his insulin, reducing his insulin, reducing his insulin, and then he'd be off of insulin, right? So that's the type 2. But with LATA, you've kind of got a spectrum there. If you remember earlier, I said a latent autoimmune diabetes adulthood treated as a type 1 versus as a type 2. I'm treating him as a type 1. He needs basal bolus insulin therapy to get this. He's doing great. I wouldn't change anything. But I do have a subset of the population that their honeymoon phase is even better than his, and just a little bit of their pancreas is not functioning. And they can get by with oral pills. And I've been successful with treating them as a type 2. So it really depends on where they are on that spectrum, and that ultimately can change over time. As they get exposed to different things in their environment, they get illnesses, revs up their immune system, the beta cells will take another hit, and then they need a change in their therapy, and eventually they might need insulin at some point. That all make sense?
Okay, so for a provider, if he's ordering those tests, the autoimmune tests, because I don't think they routinely do that, but say they did and that they were positive, they would know that there's probably not going to be that honeymoon stage or whatever, and they need to continue with that? Or is it...
No, they could still have the honeymoon stage. So if they're a LATA, they could absolutely have the honeymoon stage if we're making this diagnosis late in life. But it just lets us know that they're LATA, they're latent autoimmune diabetes adulthood, and gives us an idea of kind of the progression of this disease, or at least the potential progression. There's a good chance that they're going to need to stay on insulin like this guy did. Less likelihood of being able to treat them as type 2s. And if you do treat them as type 2s, eventually they'll still have that risk. So you got to keep that in mind. Yeah, in my mind, they're different. They're different pathways, different disease etiologies, so it's very valuable. Was that a cool case or what? That was real. I saw that guy. Okay, next, 43-year-old, 6'2", 114 pounds. What? He was down to 90 pounds at one point in his life. 2 to 3 years prior, he had been, his blood sugar checked at his partner's dad's meter, and it was over 500. So what did he do? Like, oh well, it's a little high. At the time, he didn't know what that meant. Formally diagnosed with diabetes about 6 months prior. He had lost 60 pounds in 1.5 years. He was eating a ton of food, and he felt like he was going to die. When I met him, he felt like he was going to die. A1C is 10.2%. Yeah, this really happened. He was referred to me by the wound center because he had a foot ulcer that wasn't healing. No other symptoms. He's got chronic diarrhea 8 times a day. You're getting the like, oily stools, and he's got a history of heavy alcoholism. So here's the case of diabetes type 1 secondary to chronic alcoholism, or secondary causes. So what type of diabetes is he? I think we just said. Yeah. Diabetes from secondary cause. Yep. Pickle the liver, pickle the pancreas too. Type 1 secondary to chronic pancreatitis from alcoholism. The CT will confirm the diagnosis, and you can also rule out pancreatic cancer. Again, weight loss, you should make sure it's not cancer. But the difference there in the history, cancer patients won't have the appetite, whereas the chronic pancreatitis patients will. So they can eat whatever they want, and they just pee it out. Great diet, huh? Problem is you're losing your eyes, your kidneys, and your feet at the same time. So he wasn't checking his sugars prior to his initial visit. So what would I treat this guy with? Duh. Basal insulin therapy. That's exactly what I did. Say it one more time. Oh, I can't remember. Do you remember? He was on metformin. Somebody thought he was type 2. Treated him as type 2. Gets it late in life. It's got to be type 2, right?
Isn't that a side effect though?
Oh, yeah, diarrhea. Mm-hmm. Yeah, that's a good point. I got him off the metformin anyway, so. I also put him on, right. I also put him on pancreatic enzymes. So pancreatic enzymes in chronic pancreatitis gives you the enzymes you need to be able to start breaking down your food and digesting your food that you eat. You got to take it prior to each meal. The guy started gaining weight. His diarrhea went away. No more diarrhea, weighs up to 136 pounds. A1C was 6.8. Yes. That's down from 10.2. Yes, I do see that. I get jazzed. Say it one more time. Well, at that time, it was. Actually, is this where he is now? He's a thin guy.
But I think he's actually at 143.
Okay, thank you. He's 6'2", up to 143. Still thin, but a lot better than when I met him at 114. A1C, I can't remember if this is accurate or not, but he was able to keep it at 6.8. He's still fighting lows. He still continues to drink. I had him off alcohol for a while, and he was doing beautifully, and then he went back. And the blood sugars crash overnight because of what the alcohol does to the liver. So I don't want him having lows in the middle of the night. So we're doing the best we can with him. Side note, his partner, he had a low blood sugar and passed out. And his partner had to give glucagon to get him back awake. And at that moment in time is when he decided to pull out the instructions and read how to give glucagon. And of course he was shaken because his partner's on the ground passed out. So it's a good reminder to educate your family members or people who would be given those shots. Make sure you know ahead of time so you don't have to learn during the crisis moment. He ended up doing just fine, but he told me, he was like, yeah, I was reading and shaking. Yeah, poor guy. So take-home points. Evaluate blood sugar readings helps identify potential issues with diet and or medicines, right? Educating patients on the timing of their insulin and doses is key. That's really the magic behind what I do. And it's all about, in my mind, the bolus insulin. That's the trick, matching the carbs that they eat with the insulin they take. An insulin regimen should be individualized to patients' schedule, lifetime, and social determinants. I understand that the patients you guys deal with are very complex. They can't handle carb ratios. They don't know how to count carbohydrates. But we've heard it over and over and over, at least if they can be consistent. Be consistent with a moderate amount of carbs day in and day out, then we can adjust the insulin accordingly. So consistency is key for this population. Got another break. How'd I do?